Hello, everyone. Welcome back. This week, we're going to be covering coding congenital anomalies. And welcome back. As discussed, we're going to be coding congenital malformations, deformations, and chromosomal abnormalities. Yes, there are even codes for these types of chromosomal abnormalities. Everything from this chapter starts with the letter Q. And these cover any congenital malformations from the nervous system, Q0 through Q07, Q10, Q18, eye, ear, face, and neck, Q20 through Q28, circulatory system, Q30 through 34, respiratory system, Q35 through 37, cleft lip, cleft palate, Q38 through Q45, the digestive system, and Q50 through Q56, genital organs, Q60 through Q64, urinary system, Q65 through 79, musculoskeletal system, Q80 through 89, other congenital malformations, and then Q90 through 91 is reserved again for those chromosomal abnormalities. So the first step is to understand exactly what a congenital anomaly and a chromosomal abnormality is. Let's take the easy one first, which is the second bullet point. A chromosomal abnormality is an irregularity in either the number or the structure of chromosomes that alters the course of the development of the embryo. A congenital anomaly, sometimes referred to as a malformation or deformation, is a irregularity. It's some sort of abnormality that's present at and existing from the time of birth. Congenital conditions are grouped into subcategories to identify the type of condition. So Q61 for cystic kidney disease and the specific form of it that cystic kidney disease has. And there are other categories that provide specificity according to the anatomical site and the combination of whatever the conditions are. These codes are not used on the maternal record. They're only used on the infant or the patient's record. And if an infant's born with a congenital anomaly during the encounter, the first code is from Z38 for the newborn status, and an additional code is used for whatever that congenital condition is that's present at birth. Now, if the infant, again, as we've talked about and touched on earlier, you're a newborn once. So if an infant is born in one place and transferred to a specialized NICU at a second hospital, the principal diagnosis is the congenital anomaly. Why? It goes back to that definition of what a principal diagnosis is. It's the condition after study that caused the admission. Now, we always think of these congenital anomalies as just pertaining to infants, maybe newborns, but they can be used throughout the entire life of the patient as long as the congenital condition is still present. If the condition is corrected, there is a code, and there's a code for a personal history of corrected congenital malformation, the Z87.7. And there are a whole lot of additional notes in the tabular. I would suggest you look at them, starting with some of these main terms that you see here. These include such things as spina bifida, cleft lip, cleft palate, and then you'll see some of those additional notes that you have to pay special attention to. And under section Q90, Down syndrome, there's a note that reminds the coder to use additional codes to identify any associated physical condition or degree of intellectual disabilities that are present. And there are definitely chapter-specific guidelines. These are in your textbook. These are in the chapter 17 itself. And these are basically spelling out and are consistent with what a principal diagnosis is. Some of these codes may, underline may, be a principal diagnosis. If a baby's born at another hospital, they have some sort of congenital malformation that causes them to be transferred to a specialized hospital, that congenital anomaly will be the principal diagnosis. However, at the hospital where the baby is born, you would still code it, it just wouldn't be the principal. Why? Because the reason for admission was being born, so it would be the newborn code. And again, kind of touching on what we'll cover a little bit later this week, manifestations that are an inherent component of an anomaly are not given separate codes. So if it's part of it's kind of like signs and symptoms. If it's an inherent part of that disease, we don't assign a separate code. It's understood to be included. And there are additional codes that are assigned for any manifestation that is not an inherent component. And a lot of times we'll see unfortunate infants that have more than one congenital anomaly. If this is the case and they are not inherently a part of the same established diagnosis, we would use more than one code as needed. And again, these codes can be used throughout the life of the patient. And if whatever the deformity is corrected, we use a personal history code. And as we've talked about in the first couple of slides, all these conditions are organized by body system, cardiovascular, respiratory, what have you. Some of these you can use as main terms such by the eponyms, such as Down, Patau, Edward. And chromosomal abnormalities are classified into 9 different categories. And these are the mosaicism, translocation, all these other different types of abnormalities. And again, there's different types of congenital anomalies. We can kind of think of this in 3 broad terms. There are the chromosomal disorders that can either be hereditary or arose during conception. There can be things that the neonate, the baby, was exposed to in utero, such as drugs, alcohol, cigarettes, industrial solvents, whatnot. And then there's the mother's illness during pregnancy, such as rubella and some of these other things. And the stage of fetal development at the time of exposure to one of these later 2 causes is critical. The fetus is most vulnerable in the first trimester. Congenital defects of the nervous system, the Q00 through Q07, involve the brain, the spinal cord, and the associated tissue. This includes the neural tube defects, the microencephalus, hydrocephalus type of thing, and spina bifida. Spina bifida is a defective closure of the vertebral column. When a congenital neural tube defect, which there was a development anomaly. And figure 20.1 in your text talks about the 3 most common types of spina bifida. Let's take a quick look at those. And here we have it. Again, what is spina bifida? This is when the vertebral column does not close. And it can be severe, right? Not so severe. In spina bifida cystica, the protruding sac just includes the meninges. Right? And we also have the myelinocele, right? More serious. And again, this is all explained a little bit more clearly in figure 20.1, which unfortunately I don't have at this point. But you can see these types of things very, very commonly. Again, spina bifida is in fact the main term. And we have congenital defects of the cardiovascular system. This is another area where there'll be frequent directions in the tabular, right? Hypoplastic, things like syndrome, patent ductus arteriosus, atrial septal defect, ventricular septal defects, and pulmonary artery anomalies. These are things where you need to understand what the four chambers of the heart are, the different terms, and it's helpful to understand what these structures look like. There are also respiratory system defects that are coded to Q30 through Q34. These involve the lungs, the trachea, and the nose. We can have lung hypoplasia, dysplasia, the underdevelopment, abnormal development, frequently seen in preemies, and there are other defects as well. And that's all I have for you. In the next lecture, we'll continue discussing congenital anomalies and get into chromosomal abnormalities. We'll see you then. Bye now.